Being here such a long time, being one of the early migrants from 1973, I was born in Uganda. Studied there till I was 14 years old. Dad comes from Ludhiana in Punjab.
Oh, okay.
So that's why I can speak Punjabi. Probably 5-10 years I was the only cardiologist on call for intervention. So life was hectic. You couldn't go to movies, you couldn't go do this, you couldn't do this because you had to be available. Why do we want to put a stent in? What's the reason for that? More fruit, more vegetables, a handful of nuts is a good idea. Avocados are good, for example, because they've got good fatty acids in them. Soy is good for you, berries are good for you. We wish people have less heart attacks, we wish people have better lifestyles. Our ultimate aim obviously is to prolong people's life. My gut feeling is the exercise is probably more important in that setting. This misconception that stenting means I now have no risk of having a heart attack, it's not true.
Good everyone, my name is Navneet Anand from aajKal, local and global. Today we will be talking to Dr. Anil Aggarwala, a special expertise in the interventional cardiology. Dr. Saab, welcome to the show.
Thank you. Thank you, Navneet.
I said Dr. Anil Aggarwala.
That's right.
What's the story for the A behind it?
Okay, it's an interesting story. It's supposed to be Aggarwal.
Hanji.
My father left India 1954. He was only 21, 22 years old.
Ji.
Went to Uganda, East Africa.
Right.
Somewhere along the line there was a clerical error. Someone put an A at the end of the name. And then by the time he got to Uganda, there was another legal document. It got to this stage where it was easier to leave it as Aggarwala rather than change it back to Aggarwal. So when we came to Australia 1973, so we were the only Aggarwalas in Australia. And so I didn't think there was any other Aggarwalas worldwide, but I think there are some Parsis who are Aggarwalas. And ironically, when I went to Ground Zero in New York and I looked at the list of those the persons who died, there was an Aggarwala in there.
Okay.
So that was quite interesting for me. So must have been a Parsi, I suspect.
Tell us something about your journey in Australia so far.
Okay. Well, as I alluded to, Dad left India 1954, young person, employed by the British government, went to Uganda. He worked his way up, became a school principal over there. Mm-hmm. I was born in Uganda, studied there till I was 14 years old, and then Idi Amin came in 1971. 72, he decided all the Asians had to leave the country. So we, as youngsters, me, my brother and sisters, we left India because Dad wanted to get us out because it was starting to become a bit dangerous. So we left at the end of 1972, went to India, just in transition for a couple of months. He finalized his work, and then we fortunately came to Australia, 16th of April 1973. So I did my high schooling here, I did my university here. And so, I started doing medicine in 1978 and then went through the system, went through Westmead Hospital, Prince Alfred Hospital, St. George Hospital, and then went off into private practice.
So where in India you guys come from?
Dad comes from Ludhiana in Punjab.
Oh, okay.
So that's why I can speak Punjabi. Uganda was also a lot of Indians, so we could speak Punjabi. तो पंजाबी बोलते सीगे, गुजराती भी उदो बोलते सीगे, स्वाहिली भी बोलते सीगे, लेकिन वो ऑस्ट्रेलिया आके हिंदी तो पंजाबी बोल सकते हैं. Parents नाल ही रहंदे सीगे. So I used to speak Punjabi. Mom unfortunately passed away 9 years ago. Dad passed away 6 months today. So that was a tragedy. But look, I enjoy speaking Hindi. I enjoy speaking Punjabi. I get better rapport with some of my Indian patients. So I think I've got the best of both worlds.
How has the childhood been for you?
Look, childhood was, I think I've had a magnificent childhood.
Wonderful.
As I said, extended family, really, to be frank, I've probably mentioned this a lot of times, came from really very little beginnings. We had really no money. Middle class family, and we sort of worked our way up. My roots are still on the ground, so yes, I make more money now. I was probably happier as a teenager and as a 20-30-year-old. Now I enjoy what I do, but life is hectic. Life is busy. I work 14-15-hour days, so my life is busy. But I enjoy what I do.
Being an expert in a particular field, and especially with the cardiology, definitely there's a lot of pressure from time to time. There would be emergencies that come through.
Look, the emergencies do happen. I'll be frank, I don't get stressed. I don't get stressed with these things. I'm sort of fairly easygoing person. It takes a lot to stress me out. But
I like it. It takes a lot to stress you out.
So in the early days, I mean, when we first started, to be frank, I did the very first angioplasty at Northwest Hospital, the old Hill. It used to be the old Hills Hospital up on Windsor Road.
That's right.
Then it went to this new site. But I did the first angioplasty there. I did the first 100th angioplasty there. So I was probably the most prominent interventional cardiologist at that hospital. In those days, for probably 5-10 years, I was the only cardiologist on call for intervention.
Okay.
So really 24 hours a day, 12 months a year, it used to be me. So life was hectic. You couldn't go to movies, you couldn't go do this, you couldn't do this, because you had to be available for people having acute heart attacks. I think so that incidence is decreasing,
right?
Because people are looking after themselves. There's less smoking. The cholesterol is being dealt with a lot better. There's certainly a focus on
probably awareness has been more than what it used to be.
The younger breed in particular are looking after themselves a little bit more. So we're certainly seeing less of those acute heart attacks compared to what we used to see 15-20 years ago.
Good to hear that. So what is the latest breakthrough in the heart disease management?
I think, look, there's still big focus now on diet and exercise lifestyle. When intervention first started 30 years ago or something, there was a lot of let's do angiograms, let's put stents, let's do this, and we're now taking a little bit of a back step, in fact, and probably not being as aggressive in terms of the intervention, but more in terms of primary prevention, managing the cholesterols, managing blood pressures, managing diabetes, trying to prevent the heart problems or slowing down the progression of these things rather than sort of jumping in with the more aggressive stuff. Before, if someone had slightly positive stress, we may go to an angiogram. Now, the big focus last 4-5 years has probably been on the CT calcium scoring, the cardiac calcium scoring test. So a lot of patients are now coming and asking for that. But again, we have to be a little bit careful. You don't want to just do that willy-nilly on every patient that you see. They have to have risk factors. They really should have some sort of symptoms. Or if someone has premature family history, if someone has multiple relatives who are having heart problems in their 30s and 40s, they should have a CT calcium scoring test, or if they're symptomatic, maybe even a CT angiogram. So that's probably been the big change the last few years, the focus on looking at non-interventional type investigations. The second thing, I suppose, is in the early days, if you had an angiogram, there was a 60% blockage. The tendency was, let's go ahead and put a stent in. I mean, I was still conservative. I tended not to do that. But, and a lot of my colleagues would say, let's 60%, 70%, let's just put a stent in. Now we sort of step back and say, why do we want to put a stent in? What's the reason for that? So you really have to have symptoms, symptoms before you should go and put a stent in. If someone's not symptomatic, you're best off managing that with medications and lifestyle rather than rushing in and putting in stents or bypassing things.
Before I proceed further to my next question, just want to say thank you so much for taking the time out and visiting the studio to talk about it. You have worked as a consultant interventional cardiologist in Sydney for over 26 years.
That's right.
To tell us about the transition in cardio scenario.
Well, cardiology, as I said, 30 years ago, there was a lot of smokers out there, for example. Probably incidence of smoking was about 40%. I think with education, that's probably come down now to about 20% of the population who smokes. Cholesterol management has become a lot more aggressive, so people are watching what they're eating, less saturated fats and less fried foods, less takeaways. I mean, it's obviously there still, but at least people are getting more conscious of this. People are becoming more conscious of obesity and trying to keep their weight down. Diabetes, we're still struggling with. The incidence of diabetes, unfortunately, is increasing.
Okay.
And that is worldwide, mind you. And we, as from the Indian or Anglo-Indians, have a very high incidence of diabetes. The Fijian Indians in particular have a very, very high incidence of diabetes. So we have to be very, very careful in that patient population. So certainly on positive side, less smoking, less obesity, the hypertension, blood pressure is being managed a bit more aggressively now. Certainly, hopefully less drinking, and on a positive side, probably less intervention now compared to many
what it
years
was
ago.
a few years ago.
That's right.
You are the director for the Cardiac Health Institute here in Australia as well. So what do you suggest to prevent the heart disease?
Yeah, look, I've been with this Cardiac Health Institute now for the last 15 years. So I used to be in another practice where I wasn't a principal. I used to work for someone. 15 years ago, me and one of my business colleagues decided to go into a joint venture, and so we run Cardiac Health Institute, and we try and provide all standards of care in cardiology, and that means primary prevention, secondary prevention, education, whatever it is. Our main advice in terms of preventing things again is advising about diet and exercise. So the diet is simple thing. I mean, I'm not into fad diets and Atkins diets or crash diets or anything like that. I think patients should go onto a diet which they are able to maintain for the rest of their life. So and I say to my colleagues, even if someone's had a heart attack, if they're at a party and they want an ice cream, well, you have an ice cream. If you're having a barbecue or something and there's some sausage, yes, have a sausage. It's not a problem. But you don't want to do this on a regular basis. So trim the fat off meat, take the skin off chicken. Not too many eggs, not too many dairy foods, more fruit, more vegetables, handful of nuts is a good idea. Avocados are good, for example, because they've got good fatty acids in them. Soy is good for you, berries are good for you, so more fruit, more vegetables. Our Indian diet, as you know, has lots of fried foods.
That's right.
Samosas are fried, puris are fried, chole bhatures, all these things are heavy. They're heavy, and it doesn't mean you stop it, but you have it once in a blue moon. If you have chapatis, don't put your ghees and your oils and things like that, just sensible things, and regular exercise. And one would normally encourage 30-60 minutes of brisk walking, not just gentle walking, but brisk walking, preferably at least 5 days a week. If you can do it every day, that would be better. So carrying little counters, and most of these iPhones or smartphones have little counters now. You can see how many steps you're doing, so you can keep track of these things.
So what is in your wish list?
Look, my wish list is that we can minimize the incidence of heart disease. That is the wish of everyone. I mean, we wish people have less heart attacks. We wish people have better lifestyles, and our ultimate aim obviously is to prolong people's life. But not only that, but we want to improve the quality of life.
That's right. That was my next thing I want to add up.
So the quality of life is probably much, much more important than the quantity of life. We want patients' well-being. We want to obviously lead a happy life ourselves. We do. Our lives, cardiologists' lives are hard. I mean, not because mine. Every cardiologist leads a hard life, but it's a question of how you deal with that. You can say, well, I'm achieving satisfaction with this. Some people can perceive it as a job. And some people feel, well, it's a privilege.
It is an absolute privilege. The responsibility is taken as a privilege. Probably is the easiest way to deal with it.
I'll be frank. I mean, one of the most satisfying times in the early days used to be when you get called out at 2 o'clock in the morning, 3 o'clock in the morning. It's a 40-year-old young man, 1 kid, 2 kids, and you get called in because they're having a big heart attack. And they're rolling in pain. You get to the hospital, you quickly take them to the lab, you get the artery open hopefully within 10 minutes or so, and they're pain-free. You can see it, just literally they're on the table and the pain is gone. And you've prolonged the patient's life, that you've relieved their pain, and it's satisfying. It is really just so satisfying right at that moment. And then obviously those patients become your lifelong patients, so it is satisfying.
I think the blessings that come from the family that time is 100%. Bigger than any 100%. Wealth one can have.
100%.
What are your special interests?
Look, I'm a family man, and
Yes.
so my family is very important. I've got 3 lovely girls. One of them is married, so I've got a lovely son-in-law.
And you got a grandchild.
I had a grandchild born on the 7th of January, my first grandchild. So, and my second daughter is getting married in June. So I'm gonna have another lovely son-in-law. So I'm blessed because I've got lovely girls, and I've got lovely son-in-law and a son-in-law to be. And my wife's very understanding, and she's been my pillar and rock. So, and I've been fortunate in that I've been in an extended family. I've had my parents with me. Unfortunately, I don't have them anymore. And to be frank, I mean, being here such a long time, being one of the early migrants from 1973, my brothers and sisters are all close by. So, and we sort of very close to each other. So for me, it is ironic, when you have weddings or functions, and then with this COVID in particular, it has been a moot point because, you want to have a wedding, and then you say, hang on a minute, there's 50 people just from extended families.
Whom do we get in?
So because with COVID restrictions, who do you drop out, and it's not just the immediate family, because my brothers and sisters have their kids and they're married and they've got their in-laws, and so there is really quite an extended family. So we're blessed.
So when we have to pick the diet and the exercise, which is more important?
My gut feeling is the exercise is probably more important in that setting. The reason I say that is, if you take cholesterol, for example, the diet and exercise, the combined effect of that, it only brings it down by about 10%.
Okay.
Whereas, if they have to be on cholesterol tablets and things like that, that brings it down anywhere from 30 to 55%. So the major bang for your buck is still with the medications. So I'm not suggesting everyone with a cholesterol problem should go onto a cholesterol tablet. I think the diet and exercise are important, but the medication in that setting is also very important, particularly if they've had a cardiac event. So if someone's had a heart attack, they have to be on a cholesterol tablet, even if their cholesterol is normal.
Okay.
It's a very, very difficult concept to get across. So if someone's cholesterol is 4.5, and they'll come to me and they'll say, but doc, my cholesterol is normal. And you say, well, no, it's not. Because if you've had a heart attack, your cholesterol needs to be 4 or less. And your bad cholesterol, which is the LDL, needs to be 1.8 or less. So we have to be very aggressive with cholesterol lowering in these patients. Second scenario is if someone, and you may find this surprising, if someone has diabetes, their risk of having a heart attack is the same as someone who's already had a heart attack.
Okay, that is something new.
Yeah, so anyone who has diabetes is automatically at high risk of having heart attacks and cardiac events. So this is why anyone who's a diabetic, we say you should be on a cholesterol tablet. And they'll say, but doc, my cholesterol's normal. And you say, no, it's not, because your cholesterol needs to be 4 or less. So even those, a lot of diabetics have little bits of plaque in their arteries, 20%, 30% type blockages. So even those can cause heart attacks. There is a misconception out there that heart attacks happen because of 80, 90% blockages. That's not correct. A 10, 20, 30, 40% blockage can also cause a heart attack. And the treatment for that normally is cholesterol lowering. And if you know you've got those mild blockages, then you should be on some aspirin.
Talking about the blockages, what's your take on stents? Because normally when we see there's a blockage, people go in and then they come out with the stents.
Well,
so what's your take on that?
A stent, the only indication for a stent is if someone is having symptoms. So if they're having chest pain, be it with physical activity, or they're getting undue shortness of breath, then yes, there is a role for stenting, but that is to relieve symptoms. Okay, very important. It does not
eradicate the issues that
it doesn't
heart attack
get
will
rid
never
of any
happen.
plaque. It's just the 90% blockage will become a 0% blockage, but it doesn't really decrease your risk of having a heart attack. So the only reason for putting a stent in is to relieve symptoms. Okay, so now if someone has multiple blockages in all the 3 arteries of the heart, and then and you have to put stents in all the 3 arteries. In that particular patient group, yes, you may be improving their survival. So in triple vessel disease, certainly there is a benefit in terms of stenting. But a lot of patients, and unfortunately, patients from the Indian subcontinent and all have this misconception that stenting means I now have no risk of having a heart attack. It's not true. And I've had lots of other patients who have come to see me where they've had an angiogram elsewhere. Someone's told them have a stent put in, and I look at them and they're completely asymptomatic, and I say, don't do it. Don't have a stent put in. Just go on to some aspirin, go on to a cholesterol tablet, look at your lifestyle, and certainly have this thing monitored, but don't have a stent put in, because it's of no benefit. We'll put stents in. I disagree with that. They shouldn't unless the patient is symptomatic. Or the second scenario is if they've got a very strongly abnormal stress test.
Okay.
So if the stress test says there is a large area of the heart muscle which is potentially affected, and you can see that on a stress echocardiogram or something, then yes, there is some merit in considering a stent, but the blockage has to be more than about 70%.
That's very interesting. Yeah.
And there are a few things that we can use at the time of the angiogram. We can do a thing called a fractional flow reserve study.
Okay.
They put some little wires down across the blockage, and we can measure the pressures across that, and that gives us some indication as to whether that blockage is significant or not. So if it's not significant, then you should leave it alone, but still manage it with the risk factor control.
It has been wonderful talking to you. Before I wrap up, any of the message for all the audiences and the listeners, how to keep the heart healthy?
I think the message again comes back to lifestyle is important. So some regular exercise, preferably 30 to 60 minutes of brisk walking, watching your diet, so not too much cheese, not too many eggs, not too many dairy foods, trim the fat of meat, take the skin off chicken, think about a handful of nuts, walnuts and almonds are good for you. More soy in your diet, more berries and fruits and things like that. Make sure that your cholesterol is under control, preferably less than 5 as a total cholesterol. If you already have heart disease, or you've had a heart attack, you've had a stroke, you've got problems with blockages of the arteries and the legs, then you should aim for a level of 4 or less. If you're diabetic, you should aim for a level of 4 or less. As I said, don't go for fat diets. A Mediterranean diet is good. Avoid fried foods. I think just simple things in life. Don't go into the fatty, into the fat diets or anything like that. Just regular exercise. Watch what you're eating. If you want to have a binge day, have it. It's not a problem. The smoking is an absolute no-no. So some patients come and see me. You have 1 cigarette a day, doc. It's once too many. So no smoking. The occasional alcohol is okay. There's no issues with that. Alcohol in moderation is not a problem. And by that I mean really no more than 2 standard drinks a day, and you probably want to have about 2 alcohol-free days per week, and try and keep the weight down. Be aggressive with your diabetes, be aggressive with your blood pressure.
Wonderful. आज हमने की डॉक्टर अनिल अग्रवाला से बातचीत, और मैं आपका नवनीत. डॉक्टर साहब, thank you so much.
Thank you a lot, Navneet.
Thank you.
One-stop answer to your Australian education and visa matters. Gemco Sydney. Dream big, achieve big. Fiji Times. Be with the times.